morning. We have just about, I think we can start the session. I think we are still short of one or two presenters. Dr. Yang Lu is here. I don't think we have the presentation, so maybe we'll come back. Dr. Anand Parthasarthi. I think his presentation is here, but he may be coming. Vinay is here, loading. Okay. And so I think Vinay, whenever you're ready, we'll start. We'll wait for Yang Lu and Anand Parthasarthi maybe. So good morning, everybody, and welcome to this rapid fire myopia update session. We look forward to some interesting new ideas and research in the meeting, and hopefully we will get some time and chance to discuss as we go along. So thank you very much, and we'll start with, we'll wait. Hopefully the first two presenters will come shortly. So we'll start with Vinay Gupta, who will be presenting on efficacy of atropine 0.01% in preventing myopia progression and factor affecting treatment response among high myopic children.
Good morning, everyone. First, I would like to thank the APO committee to providing me this wonderful opportunity to present over here. So today, I'm basically presenting on to efficacy of atropine 0.0%, especially among high myopic subjects, and also to evaluate the factor affecting the treatment response among the same. I do not have any conflict of interest, no financial disclosures to declare. So first, before I go further in the study, I just give a brief idea why there is a need to do such kind of a study, why we need to intervene. So a lot of studies conducted worldwide had shown that myopia prevalence had been increased worldwide, including India, and even high myopic, 10% of the world population predicted to become high myopic by 2050. So if we somehow can slow or limit the extent of this myopia progression, we can reduce the risk of development of vision-threatening disease as well as improving the quality of lives of such children. So currently, there are mostly pharmacological and optical interventions are available to prevent the myopia progression. However, in high myopic subject, optical interventions may not be a good options because due to some manufacturing limitations, where like special spectacles and the orthokeratology is not available for the children which have more than -10 diopter of myopia. Moreover, atropine 0.01 had shown good efficacy worldwide, including multiple trials, LAMP trial, ATOM trials, and even among Indian subjects in the IATM study, where it had shown that atropine had reduced the myopic progression by 54%. There is very limited study available which is assessing an effect of any myopic control interventions among progressive high myopic children. That's why we plan this study to assess the effectiveness of atropine 0.0% in preventing myopia progression in these high myopic children and factor affecting these treatment responses. So in our study, we took 6 to 14-year-old children with documented myopia progression of 0.5 diopter a year, which we compared from their previous year refraction, and myopia ranging between -6 to -14. It's a single-centric study registered in the clinical trial of India. We took the ethical approval and informed consent was obtained. So intervention was atropine 0.01%, which is commercially available in India, once nightly at bedtime in both eyes for a year. The primary outcomes measure was change in the rate of myopia progression from baseline to 1-year follow-up. Also to evaluate the change in the spherical equivalent, axial length, and other ocular biometric parameters as ACD, LT, etc., which is measured using ALMAS 700. So the statistics analysis we done is SPSS software, and when the subject came, we took the brief history, we took anterior segment examination, fundus examination, all the basic examination. Then we performed the cycloplegic refraction. Then we did measurement of axial length and other ocular parameters. If we found everything is normal, there is no pathological myopia, then we enrolled the subject under our myopia treatment plan based on inclusion and exclusion criteria. Afterwards, we advised atropine 0.01% nightly at the bedtime and did the 1-year follow-up. So as to show the results, we included all the 57 children with a mean age of 9.1 years. So we found that myopia progression rate was initially 0.61 diopter, which is reduced to 0.27 diopter per year. We found significant correlations between change in axial length and change in spherical equivalent refractive error. However, there is no significant difference noted in change in any biometric parameters like anterior chamfer, keratometry, or lens thickness. In terms of treatment response, we found there was no significant correlation observed in the treatment response from baseline refractive error and age, as well as for gender or number of myopic parents. However, we found a significant correlation and treatment response based on baseline myopia progression. There is no major side effect observed during the study period, so we noted that pupil size and near vision, which was no significant difference, as well as there is no such side effect as noted or told by parents or children. So in our study, there are 8.8% children which continue to progress more than 0.5 diopter a year despite 1 year of treatment. So the 54, we observed 54 reduction in the rate of myopia progression with the use of atropine 0.0% among high myopic children. There is a small observational study conducted among Hispanic children, which also observed a similar trend, a 52% reduction in myopia progression among high myopic subjects. The mean change of AL in a study, which is 0.15 mm after a year, is as same which is observed by Dubey et al. 0.17 mm. Treatment response, we found it is not affected by any personal characteristic at baseline expected rate of progression, where we found the slow progressors have better treatment response, which is also, this is also, recently we conducted a study on atropine 0.05%, which had shown more effective response among rapid progressors. So maybe these subjects may be more suitable for atropine 0.05. So this, to my best of my knowledge, this is the first prospective interventional trial reporting efficacy of atropine 0.01% among progressive high myopic Indian children. And also this is the first study evaluating impact of atropine among high myopic children or other biometric parameters like ACD, KMNLT. The study has certain limitation, like first we didn't include any control group, but though our study is inclusive of all the progressive myopic, so it would be unethical to leave them untreated. Secondly, we had measured corneal thickness, but we didn't analyze the results yet. So results of corneal thickness was not presented in this presentation. So as to conclude, atropine 0.01% we found effective in slowing myopia progression among high school aged myopic Indian children. So given the rise of high myopia, we found that integrating atropine 0.01% for progressive high myopic children into clinical practice could have significant effects. We didn't find any adverse effect. The treatment response again is not affected by any personal characteristics. And as to assess further long-term studies are still needed to assess sustained and long-term impact. There are certain references. Thank you for your attention.
Thank you, Dr. Vinay, for a very nice presentation. How do you compare high myopes with conventionally mild to moderate myopes in their efficacy for 0.01?
Generally the study which was presented, IATM study, it's actually, we couldn't draw a direct comparison because IATM study was a placebo-controlled trial. In this, we had two different groups. One is placebo, one is control. Whereas in this study, we compare the results from the previous baseline refraction within the same group. So though the results are more or less similar, in that study we found 54% efficacy in reducing the change in spherical equivalent refractive error, whereas in this study we found 54% change in the rate of myopia progression from the previous year.
And you did find a correlation between refractive error change and
axial
length, which is not something that is reported in other studies.
Right. So generally, I believe that the one potential reason could be that in other studies, which is done mostly in the mild myope up to -1 to -6 diopter, so anti-myopia effect of atropine was observed due to change in certain anterior segment parameters, lens thickness and lens power. I believe in high myopia, maybe the anti-myopia effect of atropine is more on the axial component. So that's why we found a better correlation in these subjects.
Okay, thank you. Thank you, Vinay. Thank you very much for a very nice presentation. We'll go on to the next presentation, which is by Dr. Lee. Association is the presentation here? Dr. Lee? Lee not there, so we still have Dr. Gulia is here, I believe. She'll be presenting on pathologic myopia in Russia, the Ural Eye and Medical Study. Guli, sorry, yes. Dr. Guli from Russia.
Dear colleagues, thank you for the great opportunity to take part in the study. My talk will be devoted to the prevalence of pathologic myopia in Russia based on the population-based study. This is my financial disclosure. Studies have shown that the risk associated with the disease resulting from myopia increases dramatically according to the level of myopia. This figure shows how these risks may vary depending on the individual's myopia. In the case of individual with myopia over -7, risk of maculopathy is nearly 127 times higher. Pathologic myopia is the fourth most common cause of irreversible blindness in developed countries. Pathologic myopia often occurs in eyes with high myopia. However, its complications, especially posterior staphyloma, can also occur in eyes without high myopia. The aim of our study was to assess the prevalence of pathologic myopia and its associations with ocular and systemic parameters in the population in South Urals in Russia. The Ural Eye Medical Study is a population-based study that was conducted in rural and urban areas. It included almost 6,000 individuals aged 40 years and older, and the population rate was 80.5%. In population of South Urals, the mean axial length was 23 millimeters. Prevalence of moderate myopia and high myopia were 9% and 1.4% respectively. Longer axial length in population 40 plus in the study population was associated with older age, high level of education, higher intraocular pressure, deep anterior chamber depth, wider angle of anterior chamber, and higher prevalence of myopic maculopathy. Prevalence of any myopic maculopathy was 1.3%. Myopic maculopathy stage 2 was 0.8%, stage 3 0.2%, and stage 4 0.2%. It should be noted that myopic maculopathy as well as glaucoma in myopic eyes was one of the main causes of visual impairment. The prevalence of moderate to severe visual impairment and blindness was 30% in stage 2 myopic maculopathy. It was 57% in stage 3 and 100% in stage 4. The prevalence of myopic maculopathy increased with longer axial length. Higher prevalence of myopic maculopathy was correlated with the thinner peripapillary nerve fibrillary. This was an interesting finding. It was found after adjusting the prevalence of degree of glaucomatous optic neuropathy or after excluding eyes with glaucomatous optic nerve damage from the statistical analysis. This may mean that the risk of non-glaucomatous optic nerve damage in highly myopic eyes may increase with the width of peripapillary gamma zone in the sector in which the natural nerve fibers run and reach the optic nerve head. Also, myopic maculopathy in our study population was not related with the prevalence of open-angle glaucoma after adjusting for axial length. It suggests that besides an elongation axial length, myopic maculopathy is not an additional risk factor for glaucoma in highly myopic eyes. Since, however, of prevalence of myopic maculopathy was also associated with high prevalence of open-angle glaucoma by factor 5.85, as it's seen in the table, in the univariate analysis, glaucomatous optic neuropathy should be excluded in highly myopic eyes, in particular since the intraocular pressure often is normal in such eyes. The prevalence of myopic maculopathy was not related with the prevalence of any major disease examined in our study, such as arterial hypertension, chronic obstructive pulmonary disease, chronic kidney disease, diabetes, inflammatory hepatic diseases, hearing loss, and others. It confirms previous studies and extends their findings to a whole array of major internal medical disease without association of myopic maculopathy. To conclude, in the study population, the prevalence of myopia confirms the myopic trend also for Russia. In this typically ethnically mixed population from Russia, myopic maculopathy was 1.3%, mainly associated with elongated axial length and thinner peripapillary nerve fibrillary, being the predominant associated factors why myopic maculopathy was not related with any major internal medical disease, level of education, or gender. Myopic maculopathy may additionally be associated with non-glaucomatous optic neuropathy. Thank you.
Thank you, Dr. Gyuli. That was very nice presentation on a wonderful community-based study. I just wanted to know, how were you able to eliminate glaucoma or identify glaucoma separately or open angle glaucoma particularly?
Yes, we performed, we determined the glaucoma based on the looking at the images of the fundus images of the optic nerve head boundaries, and also from the angle glaucoma and open angle and closed glaucoma, depending on the pentacam parameters of the angle.
Okay, so all patients underwent a pentacam, or only those who were suspected glaucomas underwent pentacam?
All of the patients that were included in the study, they underwent all the examinations.
So all of them underwent a pentacam.
Yes.
That's very interesting. Intraocular pressure was also measured?
Yes.
Yes. So that was the other factor also that must have decided,
Yes, of
possibly
course.
helped in the decision of making. Thank you. An excellent study. Thank you very much.
Thank you.
We'll go back to Dr. Anand Parthasarthi, who we had missed before. So Dr. Anand Parthasarthi will be talking on optical coherence tomography angiography in pediatric myopes.
Good morning. My topic is on angiography. I'm presenting on part of our doctor from the Center for Vision. No conflict of interest and no financial exposure. The impact of myopia and OCT angio, the aim of the study, methodology, results, and discussion will be the main points of this talk. When you look at global pediatric myopia, there is an expected 50% prevalence by 2050 and 80 to 90% in the East Asian prevalence. And the critical age is 6 to 8 years, period when myopia often develops. The cost is, of course, retinal detachment, myopic maculopathy, and glaucoma, and economic burden, which is actually said to be very, very significant. There is an imaging revolution in myopia, where you had traditional methods, you went to OCT, and now there are OCT breakthrough where you're looking at vascular flow mapping without contrast, deeper tissue penetration optochoroidal, and dynamic sequential imaging. We have started from time domain, and now we are at a swept source OCT. We are also looking at enhanced depth imaging. But what are the present retinal changes in myopia, which is already known? There is a reduction of the thickness with respect to myopia progression. There is choroidal thickening, and there are macular changes. When you looked at OCT angiography, you basically looked at sequential B scans. You look at motion contrast algorithm. There is then a separate segmentation, and then you can do a vascular mapping. This is a 3D vascular network without contrast, which is a plus, especially in pediatric patients. The vascular changes in pediatric myopia reasonably well established, which is an enlarged FAZ, a capillary dropout with flow alterations, and you have reduced vessel density, which is about 8 to 12% per 6 diopters of myopia. There is, of course, some published study as well on myopia with respect to superficial vascular density and deep vascular density in terms of percentages. Our study was a prospective study where we looked at 320 eyes, 160 pediatric myopes within 6 to 18 years. We had spherical equivalent at least about minus 0.5 with an astigmatism less than 2. The important part was the OCT images need to have a quality index of at least about 7. The exclusion criteria included patients with high astigmatism, ectasias, cataract, retinal pathology, and metabolic disorders. Each patient underwent a complete eye exam. We divided it into predominantly 2 groups, which was low and high. The axial length was measured with the IOL master, and the OCT was done with the Optopolar Evo FC with 6 by 6 millimeter scans taken. The superficial density, the deep density, FAZ, and the perimeter and the circularity were analyzed. The gender, 75 were girls, 85 were boys. About 154 were in the low myopia, and we had a very small number in the high myopia category. The results mention OCT parameters in low and high myopia. When we looked at the full superficial and the deep vessel density, it was significantly less in the high myope with no significance of other parameters. In terms of the diopter and the OCT-A parameters, with increasing diopter change in the spherical equivalent, significant correlation was seen in the OCT parameters for these. we did do a plot where we looked at the superficial and the myopia with high and low density, and in both there was significant clinical correlation. This mentions the same. When we compare our present studies with the published literature, we find that there is a reduction of about 2% for the superficial and an FSN enlargement of about 0.2 mm square for per diopter of myopia. What are the novel findings for our study is you could probably look at early detection as vascular changes precede structure alteration by 6 to 8 months, a progression prediction with the reduction of the capillary density. Treatment response may be an important factor when you look at vascular metrics and a complication risk assessment. There is a practical integration for all this. One is you can do an initial assessment, you can do a risk stratification based on the vascular and the structural metrics. You can look at intervention selection, which is to choose the appropriate therapy based on OCT and OCTA findings, a monitoring protocol, which basically includes follow-up imaging on the risk strategy, which could be 3 to 6 months, which is very doable. There are, of course, some future directions in research. We are looking at handheld technology and AI integration for the data that is entered, and home monitoring devices if there is a difference, if significant variation in the assessment. In conclusion, our results indicate there is significant decrease both in the superficial and the deep vascular density in high myopia group compared to low myopia, which warrants further monitoring to rule out early pathological changes. The results highlight the potential role of OCTA in early detection and monitoring of myopia-related changes. However, the small size of the high myopes and the cross-sectional study limit further broad generalizability. The further longitudinal studies are needed to validate these findings, and we are also looking at choroidal and vascular and thickness correlations. These are some of our references. Thank you for your attention.
Thank you, Dr. Anand. So, could you identify any particular features in the OCTA that could help to predict progressors versus non-progressors?
I think we are looking at now, Rohit, at a longitudinal study. This was a cross-sectional one-time study, so it was just, I would say, an explanation study to see if this can be done, so that we now find a difference. Now we are following up those patients on a long-term follow-up. And I think probably we may need to segment it slightly tighter, and we're discussing this with our staff as well, to whether put it as mild, moderate, and severe as one separate subsection.
So why I was asking was that, yes, of course, prospective is a future course, but you may have the data of the previous year's progression and its rate. So if you find some characteristics, you could even use that to identify progressors versus non and the rate of their progression, and see if that could work. So, of course, a cross-sectional study just gives you an idea, but it would tell you what parameters maybe you need to concentrate more as you're doing your follow-up.
That's a good suggestion, Rohit. So what you're saying is basically to follow up those patients and how many progressed and go back to the vessel changes.
So, identify progressors and non-progressors today based on their historical data, and segregate them and see for differences. And they are like your highlights, which may be suggestions that they may be the ones that are going to show change as you go into a longitudinal study. So a cross-sectional will give you an idea, and a prospective will confirm or refute your possible hypothesis that you're speculating.
Put that in the paper.
Yeah, that's great. So all the best, Dr. Anand. So that was very good. We'll go on to the next one. Shish Chen is there? Yeah. Great. So Dr. Chen is going to speak on study design and rationale of the POYANG study, a phase 3 randomized clinical trial of faricimab for choroidal neovascularization secondary to pathological myopia.
I think there's a video. Sure, that's not my name.
Can you check what is the...
Yeah, okay, this is mine. Okay,
This is
yeah.
it?
Yes, this
Okay.
is. Okay, thank you. Thank you, Mr. Chairman, and thank you for this opportunity to report this study, which is a large-scale study for the myopic CNV. And my financial disclosure. So we heard a lot of high myopia cases. We heard there's complication for high myopic maculopathy. And actually, the myopic choroidal neovascularization is the most serious vision-threatening complications. It affects about 11% of all the patients with pathological myopia, and it was most common for the CMV in the patient age less than 50. So anti-VEGF agents are the current standard of care for myopic CMV, and we know that the effect is quite impressive. Only need 1 or 2 injections. However, is that the question we ask is that coming with the new entity of this new medication, faricimab, both Ang2 inhibitor and the plus VEGF inhibitor, will that lead to a greater disease control? And that lead to reduction of the neovascularization, inflammation, compared to a single agent of anti-VEGF, as we see in the neovascular AMD and the DME. So the faricimab have a dual pathway that can inhibit Ang2 and also VEGF-A, and it has been shown that the disease control with faricimab versus anti-VEGF alone has been more durable, extended beyond 12 weeks. So for example, you can see here the elevated VEGF, which is related with neovascularization and vascular leakage, or the elevated Ang2 is related not only to the vascular leakage, but also inflammation and fibrosis. These 2 factors have been shown to inhibit in the clinical trial that it can have less, for the DME, less hyper-refractive foci, have a less development of epiretinal membrane for the Ang2 inhibition part. And for the anti-VEGF, also we know that can reduce OCT volume, the resolution of the pigment epithelial detachment. And these have been shown in the DME, in the RVO, and also the DME trial. So this is, we call the Bo-Yang study, aim to enroll about 280 patients from the different regions in the world, and about 74 sites around the world. So the key eligibility criteria is that patients have to be age older than 18, and it's before no any treatment before, and to be pathological myopia, which is greater than 6 diopter, exceedance longer than 26 millimeter, and visual acuity around 2320 to 2032. Exclusion criteria include that previous user steroid, anti-VEGF, PDT, or have inflammation before. So this is study designed that to show that after the 1 injection, comparing to ranibizumab 0.5 milligram at day 1, and then start to follow up the patient monthly until 1 year later. So the retreatment criteria, meaning that if the patient have a decreased visual acuity greater than 1 line 5 letters, or have a recurrent CST, central subfield thickness, greater than 50 micron, and also appearance of intraretinal fluid, subretinal fluid, or a hemorrhage, then the patient needs another injection during this follow-up period. So the endpoint is that the change, VA change from baseline at week 4, 8, and 12. And the secondary endpoints is that from the baseline over time, the proportion of 3 lines gain, and also different period, the gain, and also the CST. And also concerning about the safety for the ocular or non-ocular adverse events. So in conclusion, myopic CME is a severe vision-threatening complication of high myopia that can occur after treatment with anti-VEGF therapy. So what in this study, we want to see if the dual inhibition of Ang2 and also VEGF could have a greater disease control, reduce the neovascularization, inflammation, and also reduce the injection numbers. Now, the Bo-Yang is evaluating this efficacy and safety over 12 months versus ranibizumab alone. So it's using a PRM approach after the 1 injections. Depends on the surgeon's investigator's criteria, and is similar to previous registered trial and the real-world treatment. And I thank you for your attention. Thank you.
Thank you for an excellent presentation. Do you think faricimab is now going to increase the duration for the gap or interval between 2 injections for CMV?
Yes, so far we see from the neovascular AMD study and also the DME. And in comparing the faricimab with EYLEA, so we can see that in the neovascular AMD, it's shown that You can increase the durability, and most important thing that you can decrease the height of the PED, which is very important indicator for disease recurrence. Is one thing. And also in the DME trial, we saw that, after the injection, the loading for 5, you can see from the fluorescein angiography, you have less leakage compared to Eylea alone. So I think probably there's some, not only the anti-VEGF response, but also some inflammation and others.
And same should be true for pathological myopia-related CNV.
Yeah, we hope so. I mean, we have to look into that.
Currently, it's still under evaluation.
Under investigation. Yes.
So
still enrolling patients.
Hopefully, it will perform the same as it has for the other maculopathies. So thank you. An excellent study. Thank you very much. So, do we have Dr. Bazao Chen? Presentation do we have? We have, but not here at the moment. Okay. Dr. Irina? Yes, okay, great. So she will be presenting on orthokeratology in patients with high myopia.
Dear colleagues, thank you for the opportunity to take part in the Congress. Myopia onset occurs most commonly between 8 and 15 years old. Over 50% of children are still progressing at the age of 15, nearly 25% at 18 years, and 10% at the age of 21. Ideally, patients for ORTK should be with mild or moderate myopia, with no myopia impairance, and with K-mean over 42, but is not like that in reality. In the manuscript by Dr. Sharm, the combination of partial reduction ORTK for residual refractive errors in the daytime was effective to slow myopic progression in high myopia children. Axial length elongation was over 60% slower in study group. The 2-year study by Dr. Shu showed similar results in the light myopia groups. Significant differences were only found between the ORTK. At control groups during the first years, the 2 axial elongation was significantly associated with initial age and treatment. We conducted a study to assess the axial length changes of ORTK lens wear in patients with high myopia and different corneal curvature profile. We examined 102 patients from 6 to 14 with myopia from 6 to 10 diopters. We use it. The observation period is 5 years with follow-up check-ups every 3 to 6 months. We had 3 groups: flat cornea, medium cornea, and steep cornea. The effect of ESA lenses is not so much the thickness reduction in the corneal epithelium in the central part, but an increase in the thickness in the mid-peripheral zone without the decompression of the center of the cornea. The flattening in the center is minimal and secondary. First clinical case is patients with high myopia and flat cornea was fitted the ORTK. Axial length growth was 0.3 and 0.03 after 4 years. This is case with high myopia with flat cornea on the right eye and medium cornea of the left eye. After ORTK treatment, axial length growth was 0.33 and 0.17 after 4 years. Another case with high myopia with steep cornea. Axial length growth was 0.45 in both eyes after 2 years.
The increase in the axial length did not show statistically significant differences in the three study groups, which slows the effectiveness in inhibiting the progression of height myopia using OK therapy. Visual acuity was higher in the groups with medium and steep cornea profile. In the groups with a flat cornea profile, 12% of patients required additional spectacle correction. So, OK therapy with overnight ESA lenses showed the myopia control effectiveness for height myopia patients. The increase in the axial length did not show statistically significant differences in the three study groups with different corneal curvature profile. Ortho-K lenses could be a good option also for patients with a flat cornea. 12% of patients required additional spectacle correction in flat cornea profile group. Thank you for your attention.
Thank you for your presentation. It was very interesting data, especially on the different kinds of cornea profile. So, I mean, in general, how comfortable are those with steep corneas in the next day? So, how long are they comfortable without glasses? I mean, when do they start feeling blurring, and till when does the effect last? Yes, particularly steep corneas, because the astigmatism may come.
Крутые роговицы, они лучше коррегируются, чем плоские.
So with the ortho-K lenses, the steep corneas are more easier to fit the ortho-K for the steep corneas, and the effect is much better. The problem is the flat corneas. Usually doctors they even don't start the ortho-K therapy with the flat corneas because it's quite hard to find the ideal size of the and ideal fit of the flat cornea. So we don't have real problems with the steep cornea.
Okay. So thank you very much for an excellent presentation. We'll just cross-check once more. Shida Chen, Kanji Kong, Li Li, Yang Lu. So I guess we have 4 absentees. Bazoy Chen has sent the presentation as a pre-recorded format, so we'll have that next.
At this conference today. Now I will introduce my research, comparison of different concentration atropines in controlling children and adolescent myopia, a study based on systematic review and meta-analysis. There are 4 parts of my contents. At present, the incidence rate of myopia among children and adolescents is globally increasing, and it has become a major public health problem, especially in East Asia and Southeast Asia. The proportion of the myopic population is even higher. Since Professor Badalosian first used atropine for the clinical prevention and control of myopia in 1978, it has received extensive attention and gradually emerged the public concern. However, the conclusion regarding the effect of myopia control of atropine at different concentrations are still inconsistent. Recent studies suggest that low concentration atropine cannot significantly inhibit myopia progressions, and there is still no clear determination of the optimal concentration for use. Therefore, we have conducted this research to compare the effect of the atropine at different concentrations on myopia control. 2 independent researchers searched the databases respectively using the key terms. The research was carried out in PubMed, EMBase, and Cochrane Library. The inclusion and exclusion criteria are as follows. After screening, a total of 201 articles were found. According to the exclusion criteria, 154 articles and that did not meet the criteria, and 28 duplicates were excluded. And finally, 19 studies were available for analysis. We used the MSTAR2 tool to conduct the quality assessment of the included studies. More than half of the included studies were of low or lower qualities. By analyzing the frequency of the lesion mentioned in the research report, it was found that the current clinical studies on atropine for myopia controls were concentrated in Asian regions, especially in East Asia and Singapore. 9 different concentrations of atropine were mentioned. By summarizing and reanalyzing the public meta-analysis and systematic review, it was found that the overall effect of atropine in inhibiting myopias is to suppress the progression of myopia by 0.48 diopters per year. Among them, the efficacy of atropine at different concentrations of 0.05%, 0.1%, 0.125%, 0.25%, and 0.5%, and 1% is greater than the average level, while the efficacy of the atropine at concentration of 0.01%, 0.02%, 0.025% is lower than the average level. In addition, the overall control effect on the axial elongation is 0.14 millimeters per year. Among them, the efficacy of atropine at concentration of 0.02%, 0.05%, 0.5%, and 1% is greater than the average effect, while the efficacy at concentration of 0.01%, 0.025%, 0.1%, and 0.125% is lower than the average level. Many adverse events were mentioned on the original studies, but the specific occurrence rates were not provided. Therefore, we conducted the frequency of the different adverse events mentioned and found that the photophobia and allergic were the most common adverse events. Other reported adverse events included blue biases, accommodation dysfunctions, corneal staining, conjunctivitis, etc. In summary, through screening the databases, we found that the currently published studies on atropine have mentioned a total of 9 concentrations. Each concentration can effectively inhibit the progression of myopia. Regarding the selection of the concentrations, atropine at a concentration of 0.05% is the concentration that can achieve maximal myopia control effect at the minimum concentration. Since more than half of the studies included in these studies are of low quality, and the research on the prevention and control of myopia with atropine is conducted in the Asian region, it is necessary to further conduct the multi-region studies to explore the long-term efficacy and safety of the atropine use in myopia control. Thanks for your watching. Welcome to contact me through my email.
So, thank you. I think we complete the session. Unfortunately, we had 4 people who were unable to present, so therefore we finished much earlier than time. So, thank you. They were very revealing and very interesting presentations all along, and I'm sure all of us are taking back a lot of interesting ideas for future research. Thank you, everybody.